Yeah. Okay. Thank you everybody to come here. This is a very special session that we have award to our young generation, the person who just graduate or still be a resident or fellow. They can apply for a Rising Star Award. And another award is for innovation, actually for everybody. So anyone who innovate new technique, you can apply either this year or next year. And we're gonna also award you at the gala dinner. And we also having a, some educational grant for you too. Okay, also at the gala dinner. All right? Yes.
Okay.
So which award you would like to apply?
I think I'm not young anymore, so I think it must be innovation.
Okay, yes, innovation.
Thank you so much.
All right.
Good afternoon, Professor. I'm such an honor for me to be here on the stage of Innovation Award. So what I'm going to share with you is about the hair repigmentation outcome in the patient with hair graying treated with exosome therapy, and not for the observational study. What we already performed the characterization and biological activities of the exosome in the hair repigmentation. As we know that exosome is the extracellular vesicle size around 100 nanometers. They have anti-inflammatory and regenerative effect. They have paracrine effect, and they have many functions. For the hair, they can promote the hair regrowth, and also they have the function about the melanogenesis also. Currently, we can combine the exosome in almost like any fractional energy-based device or procedure like microneedle or fractional laser. What we want is that to more activation hair follicle stem cell, and we had some evidence about melanocyte stem cell also. The key pathway is activation of Wnt beta-catenin signaling pathway. That is both the hair regrowth pathway and also the pathway related to the repigmentation. And any evidence about exosome and hair repigmentation? This is our first publication. This case comes to us with the polyosis circumscripta more than 10 years, and we use the technique that I published, the fractional picosecond laser, in combination with exosome. And what we get the repigmentation of the polyosis area, and the result lasts around 8 to 10 months. And what we do is we do the same treatment protocol again, and what we got is that we got the repigmentation of the polyosis area again. So I think this treatment showed the primary evidence about repigmentation of the hair with the exosome, and this is the dermoscopic examination show more black area, more black area in the polyosis. White polyosis area, and also what we see is interesting. You can see the proximal blackening of the distal white hair. So I think we can have some evidence about the melanocyte and melanin production effect. And also, what we get is a new black hair in the white polyosis area. So I think we have some evidence about hair follicle stem cell and melanocyte stem cell activation with exosome. And this is another proximal blackening of the distal white hair. So what is the evidence about the exosome and hair graying treatment? As we know that we don't know the etiology of the hair graying yet, right? And from previous study, aging, stress, sympathetic activity, or oxidative stress will cause the melanocyte stem cell to no longer repopulate to the human hair follicle pigmentary units, so making the gray hair permanent. And currently, no effective treatment available for the gray hair. Just only few case report from the monoclonal antibodies, and this is the premature gray hair. The result come from only few of the study. That's case report only. So what we have published the study about hair repigmentation outcome in the patient with hair graying treated with exosome therapy, a cross-sectional observational study. So we would like to evaluate the repigmentation outcome after the exosome treatment therapy with many modalities of the treatment. This is a cross-sectional observational case series. The major treatment outcome is that the onset of repigmentation, you can got the repigmentation after 2 or 3 treatment sessions only. And the result of repigmentation lasts long, around 4 to 6 months. And the gray hair improvement scale is quite high, around 2 to 3 or 4 scale. And in our study, the response rate is quite high, around 60%. And not only for repigment, but you can get the hair regrow also. And this is, let me show you the very interesting case. This case, you can see very significant, obviously, hair repigmentation. And what we observe with the close-up, you can see the color change from the white to yellow and brown and black, right? When we focus close-up, we can see the repigmentation, early repigmentation, as the black granule in the white hair shaft. So I think this is very interesting. And we perform the hair plug test, and you can see the distal, we still don't have any pigment, right? But you can more see the more pigment production in the proximal part. So I think we can activate some melanin synthesis in the hair shaft with exosome. Another treatment modality using the thulium laser. And my technique, I use the fractional picosecond laser in combination with exosome. And you can see the gradual change from white to brown to gold and to black color. Even in the advanced stage of AGA, you can get the hair regrowth and both in with hair repigmentation. This is the close-up examination. You can see hair repigmentation of the whitish, blackish granule in the hair shaft, blackish granule in the hair shaft. Not only for the male, the female can experience this phenomenon also. And this is the technique using fractional RF microneedle, or even microneedle with exosome. You can get hair regrowth and also repigmentation. What we would like to know is that we try to find the correlation of the clinical variable that show the response to the hair repigmentation outcome. What we found is that the shorter gray hair duration, the moderate baseline hair graying, and also the presence of AGA can get better result with the hair repigmentation with the hair graying. And what we would like to do more is we want to see what is the mechanism that exosome could pigmentation of the hair graying. First, we check that this product is the real exosome. So we have to perform one thing to check the size and shape. So we perform the nanoparticle tracking analysis system. You can see the size around 100 nanometers, and the size distribution is circle with the good distribution. And we check with another procedure with nanoparticle analysis system with the zeta view. You can see the size around 100 plus minus, and the shape of the exosome is distributed equally. So this is size, confirm the size. And then we want to see what is the shape. So we perform transmission electron microscopy. And what we found is that we found the membrane bound vesicle with the size approximately 100 nanometer. That is the size of exosome, right? And we want to see what is inside the vesicle. So we perform the microRNA profiling and validation. So we found a lot of microRNA. This is top 10 microRNA. They both have function on dermal papillae and hair follicle stem cell, and some of them have the function on the regulation of melanogenesis also. And not only for the what we have inside, we want to see their function exactly. So we perform the cell culture. This is untreated vehicle, and when we use with abutin, they will decrease the production melanin, right? But when we use with the raw stem cell dry exosome, low and high concentration, we can increase the production of melanin. So I think this is very interesting, and this is cell cultures. You can see more production of the culture with the exosome in the dose-dependent manner. Maybe we use higher dose, we can get better result from the darkening of the hair. And so from the more evidence currently, we can summarize that the exosome could help for the gray hair improvement by activate with the major pathway like Wnt beta-catenin signaling pathway, and they have anti-inflammatory, antioxidative stress. They carry a lot of Wnt protein, microRNA, and growth factor that will trigger the MT pathway, right? And they have function to co-culture with the dermal papillae. They suggest that they have function together. So the microRNA in stem cell exosome also help improve the repigmentation. So the last slide, exosome we have evidence that we could enable both hair regrowth and repigmentation with the mechanism of Wnt beta-catenin signaling pathway activation to activate the melanocyte stem cell and enhance the melanogenesis. You can combine with any procedure like microneedling or laser. However, we still need more study about the true mechanism, the prevalence of repigmentation. And I'm so honored that not only for us, but the other dermatologists from our Dr. Antonio Tosti, Dr. Michael Go also recognize our paper. Thank you to our team also. Thank you so much.
Thank you so much. Do you have questions for the questions?
So is this a method you generally apply in your clinic when somebody steps in with white hair? So because the results are amazing. So I was thinking that nobody with white hair is stepping in your clinic or leaving your clinic. Does it work with all patients or is it just a sample?
Actually, I think this is just observational study. We
Yes, I'm asking about your observation in your clinic.
Yeah.
Does it work?
Yes,
Does it work?
it's work. Yeah.
So-
The person who ignite this idea is the patient. They come to me and say that the barber shop said that, hey, what's wrong with your hair? You have get less white hair, something like that. And so I get the observation with this phenomenon.
Good. Thank you.
Yeah, I'm quite curious about the treatment effectiveness. Actually, that lasts for a couple of months, and is there any reason to explain why that the treatment effect go fading gradually?
Actually, as the result, you can observe the repigmentation after 2 or 3 treatment sections. I think this is the hair cycle phase also. And the melanocyte cycle I have reviewed is about 3 to 5 month cycle of the activation.
Thank you. Wonderful presentation. We noticed this effect some years ago when we were doing stem cells with red light in hair. And I just wonder, 2 things really. Have you considered adding in photobiomodulation to see does it enhance the effect? Or we found that hair growth was better because it reduced inflammation and prepared the scalp for penetration. So do you think that the effect with exosomes is directly on the mesenchymal stem cells on the bulb and the pigmentation not being blocked anymore? Or is it also the same effect as hair growth? I know that's a difficult question, but it's the obvious question to ask.
Yeah, I think we can, because we see the synthesis of the pigment in both in the hair shaft that turning white. So I think we can activate the melanocyte.
Yeah.
And secondly, we can have the black hair growing in the white polyosis area. So I think we can both activate the dermal pigment cell and hair follicle stem cell and maybe the melanocyte stem cell.
So it's probably an individual effect.
Yeah, I think maybe combination effect because the function of melanocyte and also dermal pigment is the synergistic function.
Yeah. It'd be interesting actually to add or to do a second paper using red light because we know it makes hair grow better. And to see does it even make the preservance of pigment for a longer period.
Actually, in my practice, I always combine with the red light.
Do you? Okay.
And I think the result, I have to study more that I think will be, but in my practice, I always combine the result. It should be better.
Okay. Thank you.
Thank you.
So next, so please introduce yourself and award that you applied. And you can continue. You have 10 minutes and then 10 minutes presentation and 2 minutes for Q&A.
Good evening, everyone. I'm Dr. Supakat Bunpetkeo, second-year resident from the Division of Dermatology, Faculty of Medicine, Ramatipati Hospital. Today, I'm glad to present my current work titled Vascular Safety of Polynucleotide Injectable, Evidence from an Experimental Models. This study was financially supported by Pharma Research Corporation. However, no funding was provided for the authorship. Polynucleotide, or PN, is a DNA-derived polymer that has become widely used in aesthetic medicine. However, unlikely hyaluronic acid or HA filler, PN does not have a specific reversal agent. Therefore, the objective of this study was to characterize the vascular behavior. Following intraarterial exposure to PN formulation with different viscosity by comparing with normal saline and cross-linked HA using an animal model. This study was designed as a randomized control animal experiment. The rapid central ear artery model was selected because artery is superficial, direct visualize, and allow the real-time assessment of vascular. 5 treatment groups were included with 10 years per group. First is normal saline at the negative control, and the second is low viscosity PN combined with non-cross-linked HA or Rejuran HB+. The third, high viscosity PN or the Rejuran S, and the fourth is higher viscosity PN or Conjuran. And the last group is cross-linked HA at the positive control. To clarity and audience comprehension, the product will be referred to by that trade name throughout the presentation. Is product was injected directly into the central ear artery at this point. A total of 0.2 milliliter was injected using a 27-gauge needle. After injection, the arterial flow was monitored for 5 minutes to observe retrograde flow and flow obstruction. Then the ear and artery were examined at 24 hours for visible transparent emboline. At day 7, clinical evaluation was performed, followed by histologic biopsy of the ear. The result: first, retrograde flow during the injection referred to the backward flow of the injection material. We observed that the higher viscosity material such as cross-linked HA and Conjuran demonstrated 100% retrograde flow. This followed by Rejuran HB+. In contrast to Rejuran S, there was no retrograde flow. Second, after injection, central ear artery and its distribution were monitored for 5 minutes. We observed that intra-arterial blockade occur as high viscosity dependent manner. Look at this graph. Persistent blockage lasting for more than 5 minutes or purple colors was frequently observed with cross-linked HA, followed by Conjuran and Rejuran HB+, and then Rejuran S. Third, at 24 hours, we evaluated for the artery and of the visible transparent emboline. Interestingly, no persistent emboline were observed in all PN group and saline group, in contrast to the cross-linked HA group as shown. Fourth, on day 7, the ear were examined to assess their clinical status. We observed no ischemia in all PN and saline groups, but in the HA group, 100% of the ears were necrosis. Look at this photograph. Normal ear architecture was preserved in the PN and saline group, in contrast to the HA group as shown. Fifth, after the rabbits were euthanized on day 7, the ear were biopsied at 3 segments: proximal, middle, and distal. This allowed the evaluation of distal tissue reaction of the ear. Look at the upper rows, which represent the normal saline group. The artery appear normal in all segments of the ear. In contrast to cross-linked HA group, the foreign body material can be observed as indicated by the blue arrows. The vessel wall necrosis is shown by the red arrow. Inflammatory cell was shown in the yellow arrow. And the last one, distal tissue infarction, was shown by the green arrow. In all PN group, no vasculitis, vasculopathy, inflammation, foreign body material, or tissue infarction were observed. This line shows the histology of Rejuran HB+, which appears similar to the normal saline group. Histologic remained normal in the Rejuran S group. No histologic abnormality were identified in the Conjuran despite its higher viscosities. In the discussion, retrograde flow is generally considered a prerequisite for proximal dissemination during the filler embolization event. Our studies show that high viscosity materials are more likely to produce retrograde flow as shown this. This may occur because high viscosity material increase intra-arterial resistance, limiting distal propagation. Interestingly, although retrograde flow was observed in the PN group, no disseminated emboline and persistent emboline were detected clinically and histologically. This may be because PN is a DNA-based polymer that can be degraded by endogenous plasma nucleate even when PN was combined with non-cross-linked HA. No permanent occlusion was observed, likely because non-cross-linked HA can be degraded by endogenous hyaluronidase. Once partial blood flow is restored, shear force may be held dispersed PN fragment, preventing the formation of the permanent emboline. In conclusion, intra-arterial exposure to PN results only in transient blood flow disturbance. No persistent emboline, ischemia, or histologic necrosis were observed. These findings support the vascular safety profile of PN injectable formulation. Nevertheless, careful injection techniques remain essential, especially using a higher viscosity PN or PN combined with non-cross-linked HA. At the end of my presentation, I would like to thank you all for listening. It has been my pleasure being here today.
Thank you. I found that talk very interesting, and it's reassuring with the rising incidence of the use of widespread polynucleotide injections that in this model it appears to be safer than HA. I'm just wondering, are there reported case reports in humans of vascular events with polynucleotides that you're aware of? Like vascular occlusion or ischemia due to polynucleotide injections in humans?
The vascular occlusion event, it not only depend on the material itself, but it depends on many factors like injection pressure or the accidentally direct injury to the vessel wall that can trigger the emboli inside the vessel. As I mentioned, this is the animals experiment model. It cannot 100% refer the vascular safety to the human. To pretty sure that in clinical practice, although our results give the basic sign from the rabbit that is safer than other material, but the precise technique to avoid injury to the artery is necessary. It's not only material.
Thank you. That was the answer I was looking for. Thanks.
Good presentation. I'm just being devil's advocate here because I stood in your position many times for award ceremonies. Can you prove to me that it's an intravascular effect because that's all you've tested for? What if it's extravascular, that it's a compressive effect either on artery or vein?
Sorry.
You're assuming that all vascular occlusion is a consequence of an interarterial effect, which may be true, but what if it's also a compressive effect either on the vein or the artery? Because if you have a roundabout and you block the exit, nothing can go in. I'm only being difficult, but I'd like an answer.
Thank you. Yes, as shown by our results, it is the viscosity dependent as well. High viscosities, PNs give more incident of the retrograde flow or backward flow. And if when the flow that was blocked for more than 5 minutes, it also showed in the higher viscosity PN. But for the blockade, it not only give right from the viscosities only, but other rheologies of injected material like there is elasticities, its G prime and others, and also give rise to its property inside the vessels as well. Also the pressure of the injection that if we push do the bolus injection, even it is a PN with a minor volume, it can give the injury to the vessel and trigger the embolization inside the vessel.
Sure, but you're still not answering my question. You're just mentioning the properties of the filler and damage to the wall. Yeah. I'm saying, is there potential that it could be a compressive effect, particularly on the vein rather than the artery? Doesn't matter. You can turn around and say, the correct answer, actually, if you're in that situation again, is say, I know it's interarterial. Can you prove to me that it's compressive. Look, at this argument has been going on for 20 years in medicine. Don't worry about it. Whether
To prove that it's not a compressive effect from pre-N or HA.
all plastic surgeons say compressive effect means nothing, that it has to be only interarterial. But for many years we said it could be also venous, and Robert Steiner and some people in the United States showed evidence of compressive effect. But
Okay, for the compressive effect of the injected material maybe needs further investigation, because in this study we mainly focus in the intra-arterial behavior, and also we
I know he's showing intravascular. I'm saying that it could be also, yeah. Oh, I'm well aware what he's showing. Yeah, yeah.
but it is a good idea to investigate more
Exactly.
in our next studies about
Yeah.
the PN safety. The next step we may start the study about the embolic, burden may add shown that is what dissolved inside the vessel, but we don't know where it is. The mechanism that I mentioned is a proposed mechanism. Maybe the next step we investigate more what happened inside the vessel, in the plexus and also the vein. Maybe the compressive effect may be keep right.
Good presentation. I'm only giving you a hard time. Don't worry.
Thank you so much.
Just want to again emphasize you have 10 minutes presentations. Introduce yourself, what award you apply to, and 2 minutes for Q&A.
Okay. Good evening, everyone. My name is Dr. Bawantep, or you can call me Dr. Moss. For today, I would like to present a topic about the a novel 4-point multi-pane HA filler injection for tear top correction with ultrasound.
Which award did you apply to?
Rising Star.
Okay.
Yes. With the ultrasound validated specimen and safety outcome. This is my profile. We also know that for the tear top area is the most common problem in the aesthetic concern that patients come to see me in our clinic. But many patients encounter with an unnatural look after HA filler injection at the tear top area. You can see at the picture below. When the patient smiles, you will see the lumping or irregularity, especially in the tear top area. I have reviewed the literature about the anatomical basis for the tear top deformity, and I found that the tear top area has combined between the muscle, orbiculis oculi muscle, orbital part, and palpebral part, include the tear top ligament. These structures are strictly adhered with each other and strongly attached to the bone. So, if you expect to inject the HA filler into the tear top and target at the under the muscle, you may have accidentally inject the HA filler into the muscle instead of under the muscle. Then I try to find out the solution of this problem. And I found with the premaxillary space, you have to know the premaxillary space has the superior border as a tear top ligament. So when you inject the HA filler into the premaxillary space, you will directly support to the tear top without any HA filler into the tear top area. For the gap of the knowledge, no technique treat the tear top without inject HA filler directly into the tear top. Let's study use the ultrasound to confirm or follow up after tear top treatment with HA filler. And no any technique combine the HA filler injection into the premaxillary space, medial soup, subcutaneous pain, or subdermal pain at the infraorbital area with the blunt cannula. For the material and method, this was a prospective single-arm pilot study. 5 healthy Thai female volunteers aged between 20 to 40 years old with visible tear top deformity but without prominent any eye bag. Key inclusion criteria were a positive or neutral facial vector. A neutral facial vector is mean when you see the patient at the profile or the lateral view, the anterior projection between the anterior corneal surface and the anterior cheek must be in the same line. What is a novel 4-point multi-pane? A novel 4-point multi-pane has 4 points of injection. The first one is the soup, you will see at the yellow circle, and the next one is the premaxillary space, you will see at the green circle, and the next one is the tear top and the inferior orbital fat area. Both of soup and the premaxillary space were injected into the deep pain, under or inferior to the ORL ligament or the zygomatic-cutaneous ligament respectively. And the next one, if you see at the tear top on the left circle and the next one is the blue circle, were injected above the orbiculus retaining ligament in the subcutaneous pain. For this picture, I want to show you compare between injected site with the novel 4-point injection technique between the uninjected site. You will see obviously result improvement, especially in anteromiddle cheek volume loss and the reach junction and the tear top deformity. Summarize the injection technique. The total injection volume was standardized at 0.5 ml per site in a deep pain between premaxillary space and the medial soup, and the 0.5 ml per site in the superficial pain in the subcutaneous pain at the lower eyelid. Where is the recommended endpoint? How do you think about this? Between superior approach and inferior approach. In my clinical study, I recommend to choose the superior approach because let's imagine between the connection of the levator labii, subpelvis, and the orbital limb. The inferior border or lower border of the inferior orbital limb acts as a origin of the levator labii, subpelvis muscle. So when you get the bun cannula into the supine or pre-cygul space and you move medially downward and target that into the premaxillary space and pass to the zygomatic-cutaneous ligament, your bun cannula will get into the premaxillary space. But if you approach from the inferior approach, how deep is proper? You will not sure where is your tip of your bun cannula between deep to the LLS muscle or superficial to the LLS muscle. For this clinical study, I use the ultrasound relation with the high frequency ultrasound with the linear 20 MHz probe and the 18 MHz hockey stick probe to visualize the infraorbital soft tissue. Clinical assessment, I use the standardized clinical photograph at the baseline and each follow-up visit immediately after 1 month and 3 months ago. Immediate images were taken in frontal, oblique, and profile view, both athlete and on smiling, to dermatologist assessment with quartile ranking, patient assessment their own outcome using the GAS score, and adverse event were reported. Statistical analysis in this clinical study, we will use the non-parametric test and Fessman test was used for repeated measure, followed by Wilcoxon silent test for pairwise comparison when relevant. Result I will explain into T category between GAS score, quartile ranking, side effect, and adverse reaction. GAS score at immediate after treatment at 1 month and 3 months after HA filler injection, most response were rated as very much improved or much improved at all post-treatment time point, indicating high patient satisfaction. From the Fessman analysis of GAS score revealed no significant difference among the 3 post-treatment visits. No patient report that experience adverse or much worse at any time. How about the quartile ranking? Most cases were graded between Q2 and Q3, and some cases may be reaching to Q4. That means the improvement score around 50% to 100% in each case. From the quartile ranking score, remains stable from the immediate post-treatment assessment at 1 month and 3 months follow-up visit. Fessman test did not reveal any statistical significant change over time at post-treatment. This is the example case from my clinical study from the standard clinical photograph. I would like you to compare between the picture at the before injection and immediate after injection. On your left side is the resting position and smiling position respectively. If you compare between the resting before and after, you will see obviously result, especially in mid-face at the under eye area. It's no any stepping or any junction include the retreat junction at the under eye area. And when this patient smiling, you will only see the lump or irregularity at the tear top area. Okay, let's see at the follow-up after injection for 3 months. She still have the natural resolve and no any lumping or any irregularity at the tear top area until smiling. And no serious adverse event and side effect in this clinical study has been reported. For this picture, I would to let you know about the ultrasound imaging in this clinical study. Let's start from the picture D. The picture D, the ultrasound probe is aligned in the mid-pupillary line. Okay, you will see the infraorbital foramen. Ultrasound image want to show you well-defined hypoechoic area of fluoro deficit within the soup and the premaxillary space. And the next one, let's see on the picture C, it has no sonographic evidence of fluid breaching into the tear top area or the orbicularis oculi muscle. For the conclusion in this clinical study, this pilot study can achieve stable aesthetic improvement with a favorable safety profile. High-frequency ultrasound confirm accurate fluid localization within the intended anatomical plane, particularly the soup and premaxillary space without extension into the OO muscle or the tear top area. These findings support that anatomical validity and clinical potential of this technique as a safer and more predictable approach to the tear top correction. Thank you everyone to join today.
So you actually recommend this technique in every patient that have tear trough?
Yes, I apply this technique in more than 80% of my patients because in Asian population, more than 50 or 60% had the tear top problem, but it's not the real problem from the tear top. It comes from the problem of the volume loss in the infraorbital area, especially in the premaxillary space. Okay, so in my clinical, I did not inject the filler directly into the tear top, but I always support the premaxillary space.
Okay, and you have 5 patients in the study,
Yes, yes.
and your conclusion is safer because you don't find any complications.
Yes, I think it's maybe less big. But in this study, I do as the pilot study. Yes, and I try to have more than study and include more volunteer in next study.
Because 5 will not be able to translate into safe.
I understand.
Yeah.
Can never skip the statistics, huh? So you could apply this method to all kind of tear trough issues. For example, if there is a pre-existing fat herniation, do you feel that it could work, will cover, or we should avoid it?
It may not cover all of the patient because many patients have directly volume loss at the tear top area. But from this clinical study, help you to have more injection point to help your patient. Some patients have already volume fulfilled at the midface area, no any volume loss at the tear top. And some patient has only the lower eyelid problem from the inferior orbital fat area. Okay, from this study, I want to encourage you to avoid injection the HA filler into the top, but you can use another point, especially premaxillary space or the inferior orbital fat. Thank you.
Respected jury member.
Yes, please. Is apply for innovation or
Rising Star.
Rising Star? Okay, from Nepal.
Respected jury members and distinguished colleagues, good afternoon. I'm Dr. Elisa Shrestha from Nepal, and I'm here to present our study on comparative outcomes of 5% minoxidil solution versus RCP serum, that is Redencel Capixel Procapil serum versus combination therapy in male androgenetic alopecia patients. I have no conflicts of interest to disclose. every dermatologist who treats androgenetic alopecia have encountered the same question, that is, doctor, do I have to use minoxidil forever? Or can I use hair serums instead of minoxidil? Or increasingly another question, can peptide-based hair serums replace minoxidil or work better when combined with it? Our study was designed to address that question. As we all know, androgenetic alopecia is the most common cause of hair loss in men, and although the exact pathogenesis of androgenetic alopecia is not completely understood, it is a multifactorial disorder with multiple pathways like genetic predisposition and androgen-dependent follicular changes. Emerging evidence also suggests the roles of altered follicular microenvironment, impaired vascular supply, oxidative stress, and stem cell dysfunction. Currently, there are only 2 FDA-approved treatments for androgenetic alopecia, topical minoxidil and oral finasteride. Minoxidil acts as a potassium channel opener, causing vasodilation and increased vascular endothelial growth factor expression, causing prolongation of anagen phase and increasing the size of follicles. As we know, there are multiple pathways of androgenetic alopecia, but the pathogenic pathways are not targeted by minoxidil alone. So that being the limitation of minoxidil. Besides that, there are other limitations of currently approved therapies like minoxidil causing scalp irritation, irritant contact dermatitis, and initial shedding, while finasteride is associated with sexual side effects and compliance issues. These limitations, along with the need to target multiple pathogenic pathways, have led to development of newer formulations like RCP, that is Redensyl, Capixyl, and Procapil. Redensyl stimulates bulk stem cells and dermal papillofibroblast, causing hair growth initiation. Capixyl is anti-inflammatory, also stimulates extracellular matrix, and also has anti-DHT activity. Procapil targets DHT by inhibiting 5-alpha reductase, also has vasodilatory property, and supports follicular anchorage. So combining these two, minoxidil and RCP, means targeting multiple pathogenic pathways that might potentially give synergistic effect. However, there are prospective comparative clinical studies remain limited. That's why this study was designed to address that therapeutic gap. The primary objectives of our study was to compare clinical efficacy of 5% minoxidil monotherapy versus RCP monotherapy versus combination therapy. And secondary objectives was the assessment of patient satisfaction and evaluation of patient safety profile and tolerability. This was a prospective observational cohort study with 3-arm longitudinal design conducted at the OPD of Dhulikhel Hospital in Nepal over a period of 12 months and with initial calculated sample size of 96. We begin with the screening phase where 96 patients were included, but after following strict eligibility criteria, 60 patients were enrolled. At the enrollment, patients choose their own preferred treatment regimen. After enrollment, we conduct the baseline visit and record the baseline parameters, and the longitudinal follow-ups are done at 3, 6, 9, and 12 months. Adult consenting males with clinical diagnosis of grade 2 to 5 androgenetic alopecia with intention to treat and regular follow-ups were included, while the patients with other causes of hair loss and recent hair growth treatment methods and contraindications to study medications were excluded. Participants were divided into 3 groups, Group A, Group B, and Group C. Group A received 5% minoxidil, applied 1 ml twice daily. Group B received RCP serum, 1 ml applied twice daily. And Group C received combination of RCP applied 1 ml in the morning and minoxidil 1 ml in the evening with primary and secondary outcome measures. Out of 60 enrolled adult males, our study achieved very high completion rates, except 2 patients in the minoxidil group. The 2 patients withdrew because of the side effect of contact dermatitis, and 1 patient from the RCP group dropped out because of personal relocation. However, Group C achieved a flawless 100% completion rate. Our study of 60 males had an overall mean age of 37.2 plus minus 5.6 years, with overall with average hair loss duration being 4.5 to 5 years. The majority of patients had grade 3 androgenetic alopecia, and we can see all the baseline characteristics are quite similar in all the 3 groups. And in this graph, we can see up until 3 months, all 3 treatment approaches track quite closely, RCP showing even better result than minoxidil. That may be due to initial shedding from the minoxidil group. But however, at 12 months, we can see the greatest clinical improvement by group C, even showing around 92% increase in hair density, followed by minoxidil and then RCP complex. Similarly, in Norwood-Hamilton grading, around 90% of the patients showed one or more than one grade improvement in Norwood-Hamilton grade, followed by group A, minoxidil, and followed by group B, RCP serum. We also implemented a validated Caraca 4 scale questionnaire to analyze patient-reported outcomes across 4 domains. The 4 domains being bald area shrinkage, overall hair improvement, hair growth rating, and hair loss retardation. And across all 4 groups, group C, that is combination group, showed highest patient satisfaction. Now coming into global photographic representation, this is group A, that is minoxidil group. We can see at the baseline and at 1 year. So at 1 year, we can see increased hair density and increased scalp coverage from the baseline. So it's a group A. And similarly in group B, we can see increased hair density and scalp coverage. So group B, that is RCP group. And coming into finally a combination group, initially in the baseline, we can see a grade 4, almost grade 5 androgenetic alopecia, which later improved to become almost grade 2 androgenetic alopecia. There were no serious adverse events across all groups. However, in group A, there were 2 patients who developed contact dermatitis and who withdrew from the treatment. And otherwise, all the patients tolerated the treatment. So combination therapy, that is 5% minoxidil and RCP serum, delivered the highest overall clinical improvement and optimized treatment response in male androgenetic alopecia. Minoxidil monotherapy showed slightly superior efficacy than RCP. However, RCP also produced a measurable, statistically significant improvement from baseline. So highest therapeutic benefit may be achieved not by replacing minoxidil, but by combining it with other additional therapies so that we target the multiple pathways of androgenetic alopecia. In comparing with other studies, in contrast to our studies, Caraca et al. Demonstrated RCP serum to be more efficacious than minoxidil therapy. However, our findings align with other growing body of evidences like by Patel et al. And Dhurat et al., where minoxidil was combined with peptide-based hair serums, and this combination showed to be superior and efficacious than plain minoxidil. And also there are other studies where monotherapy of peptide-based serums were done, and these therapies showed statistically significant superior efficacy than baseline. So from the clinical point of view, there are 2 important messages. One is the combination therapy showed the greatest clinical improvement that may optimize treatment response in male androgenetic alopecia and may support multimodal management approach. And second one is RCP serum as the potential option for patients intolerant to minoxidil, patients seeking adjunctive therapy, and as maintenance regimens. Like other studies, our study also has some limitations, those being non-randomization and observer bias, single-center study, modest sample size, and lack of histopathological correlation. These limitations lead to future directions, those being the need of larger multicenter randomized controlled trials, standardization of biomimetic formulations, and long-term comparative studies. So in conclusion, all 3 therapeutic approaches demonstrated benefit. However, combination therapy demonstrated most promising clinical outcomes with personalized multimodal therapy that may represent the future of androgenetic alopecia management, and RCP therapy may represent an alternative in minoxidil intolerant patients. So these are my references. Thank you.
Sure, thanks. As a scientist, how do you explain the fact that when you used both products on their own, they caused between 5 and 10% side effects, yet when you use them in combination, they produce no side effects at all?
Because in the monotherapy group, the minoxidil was applied twice daily. Maybe because of that, the patients developed allergic contact dermatitis, whereas in the RCP group, applied 1 ml in the morning, and RCP in the morning, and 1 ml minoxidil in the evening. And maybe that is the one factor. And another one factor being RCP may block the side effects of minoxidil as well. We don't know about that.
Could it be that one was canceling the effect of the other, which would seem like the most obvious reason?
Yeah, maybe.
Okay.
Very nice presentation. Maybe I missed this, but did you observe an earlier clinical response in either of the groups? Did you
In
look at?
RCP, yeah.
Yeah.
For the initial 3 months, RCP and combination was better than minoxidil
Okay.
because during the 3 to 4 months, minoxidil has the initial shedding. So maybe because of that, we had better response with RCP during the initial months.
Okay, thank you.
Great.
Good afternoon, everyone. I am Dr. Jabal Fernandez from the Philippines. I'm applying for Rising Star.
Rising Star.
So in our country, melasma is so common that if you have a female patient in her 40s, there's a good chance that she's in your clinic because of melasma. So let me start with the patient I'm sure we've all seen. She walks in with symmetric brown patches over both cheeks and says, "Doc, I've tried everything." At that moment, we all know the diagnosis. What we don't always know is what will finally work. Melasma is difficult to treat because of its complex pathogenesis. Lasers may push pigment deeper. Microneedling is effective but may need frequent in-clinic follow-up. And if you live in my country if you live in a country like mine, patients rarely come back. Chemical peels offer no clear advantage over topicals, and oral agents have systemic side effects. Topicals remain the cornerstone, effective, accessible, and affordable. If we already have a gold standard, why are we still searching for new treatment? The answer is simple. Although effective, its long-term use can be associated with adverse events, making it less suitable for prolonged therapy, which leads us to the research gap. We need an alternative that is equally effective. What we did in the study is use combination peptides that can target different levels of melanogenesis. This is composed of beta-white plus tyrostat and melanostatin 5. But until this study, there was no randomized controlled evidence supporting equivalence to hydroquinone for this specific combination. This evidence gap became the driving force behind our study. Our central question, is this novel peptide cream as effective but safer than hydroquinone? Our primary outcomes were % change in MASI and physician and patient global assessments. Safety was assessed by monitoring pruritus, burning, erythema, and other adverse events. This study was a single-center, randomized, double-blind, split-phased control trial. The split-phase design is particularly important here. It controls for intra-individual variation in melasma severity. One side of the phase received the experimental cream, the other received hydroquinone. Treatment run for 12 weeks with assessments at weeks 4, 8, and 12. Data collection was done in 3 phases. During the screening, dermoscopy, Wood's lamp, baseline photographs, washout period, and consent were taken. During the treatment phase, skincare sets were given with follow-up at weeks 4, 8, and 12, where MASI and PGA were recorded. At week 12, data were completed, encoded, and analyzed. And after the treatment period, the assessor continuously evaluated for any delayed side effects from the treatment. Our study included 40 patients with a mean age of 48.9 years, ranging from 30 to 58 years. The average duration of melasma was 4.5 years, and 70% reported a positive family history. Importantly, the 2 treatment sites were comparable at baseline. This baseline comparability strengthens the validity of our results, as any differences observed during follow-up are more likely attributable to the treatments rather than differences between the groups at the start of the study. At baseline, the 2 groups had comparable disease severity with no significant difference between them. Over the course of the study, both groups showed a progressive reduction in MASI scores, and at every follow-up visits, Month 1, 2, and 3, the differences between the experimental and control groups remained non-significant, with all p-values greater than 0.05. The key finding is that the novel triple peptide cream was non-inferior to 4% hydroquinone, achieving comparable improvement in melasma severity over 12 weeks. This just shows the result in graphs showing a steady decline in MASI scores over time. Importantly, both treatments demonstrated significant improvement from baseline, confirming their clinical effectiveness. But notably, the novel peptide showed faster improvement during the first month as determined by the PGA. So we've seen the graph. Now here's the clinical result comparing control from the experimental group. And again, we see better initial improvement in experimental than control in terms of PGA, and improvement converged with control by third month. Now, safety. This is perhaps the most clinically significant finding of this entire study. The experimental group, 0 adverse events across all 12 weeks of treatment. Not a single report of pruritus, burning, erythema, or any other complaints. The hydroquinone group, 3 events and 3 separate participants. 1 case of pruritus which resolved spontaneously without interrupting treatment. 2 cases of burning sensation requiring a brief 3 to 5 day treatment break before being resumed. All events were self-limiting, but they happened. So what do we make of all this? 4 points. First, efficacy equivalence. Both groups achieved comparable MASI reduction at every time point. Second, the early PGA advantage. If patients and physicians both independently perceive faster improvement, adherence improves. And in a condition with very high recurrence, adherence is everything. Third, the safety differential. A 0 adverse event rate over 12 weeks is not a minor footnote. For patients requiring long-term or maintenance therapy, this fundamentally shifts the risk-benefit equation. Lastly, the 3 peptides target different steps of melanogenesis. This just shows the complexity in the pathogenesis of melasma. Traditional depigmenting agents mainly target tyrosinase. While effective, this approach focuses on a single step of the pathway. Now let's take a closer look at the mechanism behind our novel peptide cream. Melanostatin 5 blocks the binding of alpha MSH to the MC1R receptor, reducing melanocyte activation. Tyrostat inhibits tyrosinase, the key enzyme responsible for melanin production. Beta-white downregulates MITF, reducing the production of tyrosinase and other melanogenic proteins. These 3 peptides provide a multi-targeted approach blocking melanogenesis, first at the receptor level, the transcriptional level, and at the enzymatic level. So what does this mean for clinical practice? First, it works. Second, it is safer. 0 adverse events supports long-term and maintenance use, exactly the scenario where hydroquinone has traditionally struggled. Third, patients feel it faster. Earlier visible results at months 1 and 2 are a known predictor of adherence. In a condition prone to recurrence and abandonment, this matters. Fourth, it may be particularly valuable for hydroquinone-sensitive groups, patients with darker skin phototypes, those planning pregnancy, and patients who have previously experienced hydroquinone intolerance. So we acknowledge the limitations honestly. 12 weeks may be insufficient to capture long-term relapse. Extended follow-up is the essential next step. And we studied only epidermal melasma. Dermal and mixed types represent an important unmet need that future studies must address. We also relied on MASI and PGA, validated and widely used but inherently subjective. Objective tools such as mixameter or other imaging would substantially strengthen future studies. Finally, this is a single-center trial. Multi-center replication across diverse phototypes and geographies is needed before these findings can be considered generalizable. 4 messages to take home. 1, this combination cream is as effective as hydroquinone 4%. 2, significantly better safety for long-term management. That is a decisive advantage. 3, earlier patient and physician satisfaction at months 1 and 2. In high recurrence condition, early visible results drive the adherence that makes any treatment successful. And 4, larger multi-center RCTs with longer follow-up and objective pigmentation metrics are the needed next step before this combination can be integrated into clinical guidelines. So I began with a patient who said, "Doc, I've tried everything. Perhaps today we can answer not everything. There's another option worth trying." These are my references. Thank you very much for your time and attention.
Excellent. I want to ask you two things. First of all, when you're talking about hydroquinone 4% cream, the cream contains only hydroquinone 4%, or is it triple combination cream?
It's only hydroquinone.
On
cream,
what basis?
monotherapy.
On what basis? Compound?
We wanted to not use Kligman's formula, which
No, I mean in what, like a cream, a gel?
cream.
Cream.
Yes.
Anionic, cationic?
Sorry.
What kind of cream?
Hydroquinone 4% cream.
Cream, just
Yes. Yes. Pure.
emulsify. Okay.
Yes.
And then, did you apply it just once?
It was applied 2 times a day, every day for 12 weeks.
So hydroquinone twice a day, and your cream twice a day.
Yes.
Okay.
yes.
And is it something that's ready made on the market? The triple combination, is it
The triple combination is readily available.
available in the
yes.
market? So which cream is that?
The brand name is Styrolite.
Is something here local, or is it like international?
It's from India. It's
India.
Produced by a company called FSPC in our country. It's distributed.
Okay. Just out of curiosity.
Thanks. I'm interested in your gender bias. 39-1 female to male. Does that mean that females are 39 times more interested in having their face beauty, or had you just difficulty in recruiting male clients?
Actually, I did it during my residency, so most of the patients coming in our department are females, but I actually didn't have the chance to really get a lot of males because most of the patients who presented with melasma are female patients.
No, I understand. Yep.
Since your skin color actually usually type 4 to 5, right? So the patient, the skin type usually type 4 or type 5, right? So the problem is that the improvement of the modified faces score is about 30% decrement, right? Yeah, so that's how the result can satisfy your patient, and this is the first one. And the second one is that you just apply for the whole face, or just only apply the melasma area?
It was a split face on the entire face.
Okay.
Yes.
Okay, so that's how the patient can satisfy with the only 30% decrement of the modified Macy score. I would like to know the patient's the real thought. Has there any comment if the patient not really satisfied? What will be their comment?
Sorry.
I mean that does all the patient satisfied with only the improvement, right? The patient according to the result, it's only 30% of the decrement of the modified Macy score. Is this result satisfy your patient? I mean, clinically.
If the patients are
Happy with the result.
Right.
Actually, they are quite satisfied because there's improvement, but they wanted to continue the medication even after the trial. The problem is with hydroquinone, we limited it to 12 weeks because of the side effects that it has.
It's very interesting because you know that for the trial, usually the sample is free. So if they need to pay, I'm not so sure if that will also satisfy the result. Yeah, that's what my curiosity.
And my question's a quick question. So why do you pick 4%?
Actually, it was based on other studies since the literature used 4% of hydroquinone, so I just patterned it from previous studies.
No, I'm thinking about 2%. Yeah. I'm just like, why do you pick 4%? I mean, is there any particular reason you pick 4%?
It was just based on the literature that I included in my paper. Thank you very much.
Good evening, everyone. This is Dr. Patrick. I'm originally from Myanmar, and now I'm currently studying PhD in dermatology at Mayflower University. It's an honor for me to be here on this stage in IMCAS Asia 2026. And today, I would like to discuss about harbor remedies for androgenetic alopecia, Salpa-Metrophenol, and I'm applying for the Rising Star Award. Apart from the support from my university, I have no other financial conflicts or interests regarding this presentation. And as you already know, androgenetic alopecia is the most common type of non-scarring hair loss among the population. And we have so many modalities for the treatment, starting from the US FDA approved treatment like or topical minoxidil or finasteride, FDA clear device like low-level laser-like therapy, and more fascinating therapy like the stem cell therapy, exosome therapy, and so many regenerative modalities are available nowadays in the market. I believe that everybody in this room have some kind of experience regarding this kind of treatment as well. And so for the clinician, and then so we have so many variety to choose. In the general population, they also have accessibility to some kind of treatment in the androgenetic alopecia. If you go to the 7-Eleven or any convenience store here in Thailand, you will see that there are vitamins, minerals claiming for the hair growth. And also like there are harbor lotions and shampoo claiming for the hair regrowth. And then so they are also very popular among the general population. So today I would like to check whether they are really safe and effective in terms of the androgenetic alopecia. So I will focus only on the harbor remedies. Taking back to the history, and the harbor remedies start from the Islamic medicine, and then nowadays we have the modern medicine. We can prove the effectiveness of the harbor medicine in different way. And according to the previous study in the literature, you can see that different harbor remedy, as shown in the picture, they works on the different level in the pathogenetic process of the androgenetic alopecia. The fundamental process is, as you already know, 5-alpha reductase inhibition. And also, androgenetic alopecia is now considered as part of the inflammatory process, and some of the harbor remedies act on the inflammatory pathway. And some of the herbs, they have shown that they can improve the upregulation of the hair matrix keratinocyte proliferation and dermatocyte proliferation. So there are so many mechanisms of action of the herbs in the pathogenesis of the androgenetic alopecia. These are the well-known herbs in the previous literature related to the androgenetic alopecia. But as you already know, fundamental pathophysiology will be the 5-alpha reductase inhibition in terms of the use of harbor remedy in the androgenetic alopecia. So we would like to check their efficacy and safety in two phases. The first one is about the systematic review related to the harbor remedy, which have the 5-alpha reductase inhibitory activities. And the second phase is about our clinical trial related to one of the popular herbs. Okay, for the systematic review, and then we recruited the 13 eligible clinical trial from the 312 records. For the detailed protocol, you can see in the Prospero, we already registered our protocol above this systematic review, and we screened for the 4 main databases and the great literature, and then we got these 13 clinical trials, and we got the data from more than 790 participants. Regarding the efficacy and the evidence, and then we found that, interestingly, epipprocyanidins has the most consistent placebo control replication in terms of the androgenetic alopecia. But 3 of them, they come from the Japanese daughter, and another study is about the Salpa-Melto, and then they found that it is safe and effective in the androgenetic alopecia, and also the ginger and also rosemary oil and pumpkin seed oil are also safe and effective for the management of the androgenetic alopecia. As you see in this figure, you can also see that some of the study they compare with the standard treatment like 2% minoxidil, and they claim that they are comparable to the management of the androgenetic alopecia with the standard treatment. And interestingly, there are no serious adverse effects reported in more than 790 participants, but they have some minor tolerability issues like scalp itching and transient erythema. So for the evidence quality, and we also do the grade assessment regarding these clinical trial. And yeah, according to our conclusion, that grade assessment is like the study are quite diverse in the population, and also assessment parameter. Some of the study, they just only measure like subjective outcome like the global photography, participant satisfaction, and not quite accurate. And also, if some of the study, they use the trichoscopy, but they measure the hair count, and they didn't mention about where is the exact point to evaluate the hair count and something like that. So I would say that the quality of the evidence certainty is still low. And so in conclusion of this systematic review, we will say botanical extract can be used as the adjunctive treatment, but not for the primary treatment. They cannot replace the primary treatment. So we are quite interested about the herbal remedies, and so we choose one of the ingredients, we choose one of the herbs from the previous literature, which is saw palmetto. So we got the extract from the berries of this palm tree, and then they claim that they have the 4 fatty acid in this saw palmetto, and this fatty acid has been shown that they can inhibit the 5-alpha reductase competitively and non-selectively, both type 1 and type 2. And also they have the effect on the DHT binding capacity. And also they can even block the nuclear uptake of the DHT in the previous literature. And also somebody already proved that saw palmetto extract can also has the effect on the inflammation as well. So we are quite interested about its mechanism, and so we look back to the literature, and we found that some of the study are mixed with the other ingredients. For example, mixed with the peptide, mixed with the other herbs, and then so we are not sure about the pure efficacy of the saw palmetto. Another is about the lack of the standardized measure. As I already mentioned, like they measure only the photography, participant satisfaction, something like that, but they don't evaluate like the trichoscopic picture or something like that. And another is that some of the research hugely has the conflicts of interest from the pharmaceutical company, and then so we would like to do the independent study related to the pure saw palmetto topical extract lotion. So this is our extraction process. Before our study, we did the compatibility testing for 45 days, and then so after we assume that it is ready to use, and we apply for the Thai FDA, and then we got the Thai FDA, and then we apply the ethics at the Mayflower University, and then after we got approval from the ethics, and then we start recruitment. We recruit 40 male participants in the androgenetic alopecia, stage 1 to 3 VODIS, and we did the computer-generated randomization, and we split into 2 groups, and one is the intervention, and another is the placebo group, and 36 participants completed the study, and 18 participants in each group. And then for the assessment, our primary outcome is about the increasement of the hair count. We use the trichoscopy, and we measure the total hair count, terminal hair counts, and villus hair count. And to get the standardized result, we also make the individualized plastic cup for every patient, like in this picture, and then we make a hole for every patient, and then we keep with their ID, and then whenever the patient came to our clinic, and then we ask them to use the cup, and then so we measure the mark area on the plastic cup, and then so that we can get the consistent result for every visit. So this is our study protocol, and most of the participants are in the middle age, and age is stage 2, and there is no baseline variation between the placebo and intervention. And this is our primary outcome. As you see in this picture, this is the increasement of the hair count seen by the trichoscopy. And from the baseline at the end of the 12-week study, you can see that there was 17.98% improvement in the total hair count. But interestingly, you can see up to 8 weeks, we don't see that much significant improvement. But after 8 weeks, and then the hair count improvement is significant, right? So we believe that before as the other topical treatment, and then it really takes time to inhibit the 5-alpha reductase, and then so it is one of the point that you have to consider when you talk about the topical therapy to your patient. You have to tell them that you need to be patient, because the topical therapy takes time to get the effect, and then so as you clearly see in this clinical outcome. And also, we also evaluate the terminal and villus hair count, and compared to the placebo, there was increasement of the terminal hair count and significant reduction in the villus hair count as well. We also did the subjective measurement from the 3 blinded dermatologists and also the participant satisfaction, and we found that the clinical assessment.
30 seconds.
83% improvement and 77.8% improvement was seen. And then so this is the clinical feature, and this is type 2, and this is the stage 3 androgenetic alopecia. And for the safety profile, among the 40 participants, only one complained about like transient comedones on the forehead, but the other, they said that it's okay. So we can prove that saw palmetto is safe and effective in the management of the androgenetic alopecia. And our study finding also aligned with the other previous, the published literature recently. And so I can say that saw palmetto will be one of the very fine friends in terms of the management of the androgenetic alopecia. However, you know, the friend can change anytime.
I'm sorry, you have to stop, sorry.
So
Yes.
this is the end of my presentation.
I'm sorry, because everybody have 10 minutes. So we have to be, you know,
I
equal,
understand
right?
it's finished.
So do you think we're in the same situation as we are with peptides, that because botanicals can't be patented because they're a natural product, the same way as peptides can't, that there's no proper trials been done by the pharmaceutical companies? And most of the trials we see there are sort of small single studies, minimal thing with no proper inclusion criteria and all the rest.
In compared to the peptide, right?
Well, I just mean the same logic, that pharmaceutical companies have no interest because they can't patent them.
For the patent. For,
You-
sorry.
You
could
don't
please-
understand my question.
Yeah. I cannot get your question. Could you please ask again?
Sure. You're in a situation where you're showing us that herbal remedies that are botanical are almost as effective as what the drug companies are giving us, but there's no proper trials been done except for small trials. Is it because the same situation as we have with TB 500 or BC 125 that pharmaceutical companies aren't interested because botanicals can't be patented, so they can't obviously produce them and sell them? I don't think you understand.
No, I thought that was a nice study. I think it's quite interesting that you saw such a dramatic improvement by week 12, because we oftentimes will tell patients it's going to take at least 6 to 9 months to really see meaningful improvement. So I think it'd be interesting to see even longer term kind of follow up to see if that trend continues.
Okay. Thank you so much.
สวัสดีตอนเย็นค่ะ Good evening everyone ค่ะ Today I want to present my technique in nowadays in this year for both no, rising star. Okay, this technique I call personal face analysis technique. For my experience, I work in aesthetic field 3 years. This technique is involve target injection every layer if I think it can cause the problem that my patient come to me. Every layer, something like bone, super subcutaneous, like ligament and dermis. Objective, I want to share a technique that can make your patient look natural. Personal face analysis technique, step-by-step protocol that I made by me. 1. Assessment size of your patient shape, symmetry, asymmetry, laxity, sagging, volume loss, quality of skin. Second step, communication, expectation of your patient, reality that I can do for my patient, and my skill that I want, that I can do for my patient. Third step, product selection. You can use this technique in any product, but in this presentation, I use the polynucleotide product. The fourth step, if I select the product, right? I want to lifting first. Lifting, I need to lifting upper part, neck lateral part, and lower part. From lifting technique, the fifth technique I use volume restoration, volumizing technique. After lifting technique, I will inject at the infraorbital area or lower eye area, right? And next nasolabial area, it is the lateral part of the nose of my patient. And the final, this is the chin and perioral area. The final step is the assessment, and if you think it's not enough, you can communicate with your patient. If they want to improve, we can more add volume. Key principle, this protocol, you need to select the appropriate product for your patient for the layer that you want to inject. Rheology property must match its injection depth. And the first step, right? Analyze your patient face size shape, size shape, asymmetry, symmetry, stacking, laxity, volume loss, skin quality. Method, in this technique, I use polynucleotide product V and A band. Needle type, I use sharp needle size 30 and 32. Target depth skin on bone per supraperiosteal layer, subcutaneous layer, and skin subdermal, intradermal layer. Okay, in my case, she female 24-year-old, no underlying history of filler injection at chin CCC 1 year ago. She normal size of face, oval shape, symmetry, laxity, loss of volume in the temple, lower eye, nasolabial fold, normal skin quality, because she is just 24-year-old. Okay, this is the immediate result. From I inject polynucleotide product 13 cc, immediate result, and after 1 day, this is the fully result. But if we use SA filler, right, we can wait for the fully result 1 month. Okay, next, how to inject? If we want to, my patient look natural, we need to communicate first, and this is technique. If my patient can afford every cc that you can make my patient more natural. Okay, next, temple area. I need to first lifting. I use periosteal pain at the left side of picture, the circle picture, big circle. This is periosteal pain. Needle sharp 30. Side orbital retaining ligament 0.5 cc, bolus 1 point. At the right side of picture, I use subcutaneous and intradermal pain. I use sharp needle type sharp 30. Side at the, I think that's volume loss. I inject at the lateral part first and at area that I think it volume loss. Technique I call microdot technique. Next, lateral area. I use subcutaneous pain, intradermal pain. Sharp 30. Side volume loss area, lateral first and go to medial part. Technique microdot and multiple point. Next, after I use lifting technique at the temple, right, and lateral part of face, I focus at the lower eye area. First, I use at periosteal pain, or we want to stay on bone, right? I use 30 millimeter sharp needle at the deep medial, we can say medial soup, right? Yes, I use 0.5 to 0.5, 0.3 to 0.5 cc per point. It depends on your patient, but in my patient, I use 0.5. I bolus 1 point, and at the lateral part, 1 point. Okay. Next, subcutaneous and intradermal pain, I use microdot technique. At the part that I think the volume loss. Okay. At the periorbital area. Next. Nasolabial 4 area. I inject polyosteopain needle same 1 cc per point bolus technique. And the at the subcutaneous intradermal pain, I use microdot technique. ตามภาพค่ะ Okay, next, sorry. At the final around lip area, I use subcutaneous pain and intradermal pain needle tight sharp 30. Side volume loss area, I think at the lifting periorbital area, I inject first at the lateral part of the corner of mouth. Technique microdot and bolus. Bolus on the deep part and microdot at the superficial part. If you use polynucleotide product, you can inject intradermal technique. Okay, this is the result. At the left photo, before injection, middle photo is after injection, and the left side photo is the after injection 1 day. Result is she appreciate for my skill. Okay. It's all about my presentation. Thank you very much.
Were all of the injections polynucleotides?
Yes.
I don't use polynucleotides in my practice, and I'm just wondering, when you do a periosteal injection, periosteal, like on the bone, what are the polynucleotides doing? Because I typically think about them in terms of supporting the extracellular matrix, activating fibroblasts, increasing hydration, and those are all things that take place in the dermis. So what are the effects that polynucleotides have to give lifting and support when you're doing a deeper injection?
I just use polynucleotide product in this presentation because we can inject every layer in the same product. But if we want the polynucleotide product for lifting, it's not effective more than SA filler, right? Just share technique. Okay, thank you.
I was about to ask the same thing, because you use the lateral vector techniques with a non-cross-link product, so I was wondering why you mapped the face like that. So I use polynucleotides in my practice, but only superficial, but maybe you have also good results. Thank you.
Thank you. We can change to SA filler for in this technique. But if we want to use this technique in SA filler, I suggest use cannula technique, but in the same layer that I share. Thank you. Thank you.
Good evening, everybody. My name is Dr. Umair Shahid Sheikh, and I am a plastic surgery resident from Lahore, Pakistan. Yes, for the Rising Star. So today I'll be presenting our work on donor site dyspigmentation following thickness skin grafting and specifically the role of Fitzpatrick skin type in predicting post-operative pigmentary outcomes. So the work arose from a simple observation in our clinical practice, which was that donor site pigmentation changes were common, distressing, but yet remained poorly quantified, and particularly in darker skin types. So although graft site outcomes received some considerable attention, the donor site was being neglected, and there was scarcity of literature on pigmentation patterns and especially objective data, which was scarce. So our objective was to evaluate the association of Fitzpatrick skin type for donor site dyspigmentation following split thickness skin grafts using quantitative digital image analysis. Our study included 232 donor site observations from 62 patients. Most of these patients were adults and predominantly Fitzpatrick type 4. And we followed our patients for a period of 1 year. This is the Fitzpatrick scale for reference. So how we performed the study was that we did clinical photography for our patients over serial follow-ups, and we uploaded these images on a free digital image analysis software called ImageJ. And so initially, a region of normal skin was identified adjacent to the donor site, and we used the pixel intensity values of this normal skin to establish a threshold. The software would then consider all regions darker than this hyperpigmentation and all regions lighter than this hypopigmentation. This gave us objective quantification, and it also allowed us to accurately determine the percentage area of hypo and hyperpigmented regions. So we then got mean intensity scores of dyspigmentation via histogram analyses. Using the pixel intensity values that we got from the histogram analysis, we then calculated dyspigmentation scores. For both hyper and hypopigmentation, severity was calculated as a product of the affected area and the difference in mean intensity pixel values relative to normal skin. Individual component scores were combined to generate a total dyspigmentation score. We then used a linear mixed effects model to evaluate the effect of Fitzpatrick skin type, age, and graft thickness. So what we found was interesting. We found that the Fitzpatrick skin type does indeed predict total dyspigmentation and was strongly associated with hypopigmentation severity. The effect was greatest in the Fitzpatrick 5 patient cohort with a p-value of less than 0.001. Hyperpigmentation, however, was influenced by graft thickness, with thicker grafts producing higher hyperpigmentation scores. Increasing age was also noted to be associated with greater pigmentation burden. We also saw that a pattern emerged with regards to hyperpigmentation, which was that a maximum hyperpigmentation was noted at the 3 to 4 month post-operative time period, and that progressively improved over time. Hypopigmentation, on the other hand, was persistent and remained relatively stable throughout our follow-ups. The total dyspigmentation decreased significantly with time, and the serial follow-ups here illustrate this progression. So in conclusion, what we observed was a two-phase pattern of dyspigmentation. Hyperpigmentation was initial, transient, and largely self-resolving, whereas hypopigmentation persisted over longer follow-ups and was more severe in higher Fitzpatrick skin types. Darker skins appeared particularly susceptible to hypopigmentation. And hyperpigmentation was influenced primarily by graft thickness and age. And this information can therefore be used to counsel and prepare patients for what's to come after these procedures. These are my references, and I thank you all for listening, and I'm happy to take any questions you might have.
you showed us, I suppose, donor graft mismatch, graft thickness, all being causes per se. Have all the grafts come from the one doctor? Because certainly, you know yourself, when you're doing skin grafts, people can be a bit rougher than others in terms of skin grafting.
I agree. You're talking about the user dependence of how the grafts are harvested?
Absolutely, in terms of the different doctors get different levels of pigmentation, or was it all from the one team?
This is from our institution, from our plastic surgery team, which included 4 doctors.
I see.
Yes.
And was there any difference in the doctors?
No.
Okay, thanks.
Yeah, I'm quite curious about the way you calculate. So you calculate the area, the area, right?
Yes.
Is any possibility that some, for example, taking the picture with the improper direction to make the calculation not really accurate?
You're saying the lighting conditions during the photography? Yes. So we accounted for that in every follow-up, in that the normal skin was subjected to the same amount of lighting as the donor, irregardless of other lighting intensities. So every time we subtracted the pigmentation from normal skin that was right adjacent to that donor site, which subjected to the same lighting condition, that would normalize and account for different lighting conditions to address this problem. Thank you.
Good evening, everybody. I am Pathanan Saphaibunphon from Renic Clinic, Bangkok, Thailand. I've graduated from Khon University and graduated from Srinakarin Virod University for master degree of dermatology. And I have 8 years experience about microneedle RF and 3 years experience about using it to periorbital skin rejuvenation. And this is our to invite of innovation, yes. I want to introduce all of you to join my journey with using periorbital skin rejuvenation in Asian skin using microneedle radiofrequency combined with 2% polynucleotide with a minimal invasively approach for periocular dermal remodeling. The eyes are the center of the face and often the first area we reveal aging. Under the skin periocular, there's the O muscle. When you smile, when you cry, it contracts and release and create a small wrinkle over time. Many people come to my clinic and ask, doctor, how do I treat this area just underneath the eye? What is your first choice? Botulinum toxin, filler, eye cream, or advise patient to go surgery, but I think none of this. For 3 years, I have experienced more than 1,722 procedures with 728 patients, especially with 0 complication with eye complication. At least 10 years, people investing for aesthetic medicine. She have sharp jawline, improved facial contour, and have a tighter skin. But when you talk with someone in a small area, some area that remain untreated, periorbital region. Microneedling RF is used to stimulate collagen and elastin production, but many physicians avoid treat this too close to the eye because avoid the eye complication. But if you can treat, the result is obvious and help skin quality. And this for periocular under eye darkening is improved too. And this is about 2 sessions of microneedling RF together with 2% polynucleotide. What is the clinical gap? Conventional laser we do every year is a heavy ocular protection. You have to close your eye to do the procedure, while HA filler is sometimes more tyndall effect. And botulinum toxin can treat a dynamic wrinkle on lateral eye, but the skin under the eye is unmet need. This is a missing therapeutic bit between topical skincare is more superficial, and HA filler and toxin is not good enough for poor skin quality, but for upper eyelid, surgical blepharopathy is invasive. This is a treatment protocol. I divide the patient to severity-based treatment guideline, use a multiple pass, low energy approach, and anatomically safe angular handpiece. For mild to moderate case, I use early bipolar microneedling RF. For moderate to severe case, I use most bipolar and monopolar microneedling radiofrequency. Cells of egg for mild to moderate case, and potenza is for moderate to severe case. And in some case, I add 2% polynucleotide like Plinet fast to enhance the result. And this is the first line protocol for mild to moderate skin laxity. For upper eyelid, use just a tiny needle with 0.3 to 0.4 millimeter with continuous wave mode, low energy 3 to 4, and use multiple pass 100 to 150 shots per side. For the lower eyelid parameter, you can use the more depth of needle, 0.4 to 0.8 millimeter, use continuous wave, level energy 3 to 4 with 100 to 150 shots per side. For moderate and severe skin laxity, I use potenza because potenza have both bipolar and monopolar in the same device, and you can use it at the same time. The first part, I go deep with monopolar mode in the upper and lower eyelid with 0.5 millimeter, separate the pouch to 4 pouch to decrease the pain, and use multiple pass for 100 shots per side. Second pass, I use more superficial rejuvenation with bipolar microneedling RF. For upper eyelid, use 0.5 depth, and lower eyelid use 0.75 depth. Divide shot to 4 pouch and use multiple shots. At the finishing phase, I apply the 2% polynucleotide with CP25 tip fusion tip for trans-epidermal drug delivery without any injection. This is film X is a continuous wave mode and bipolar with bipolar RF with pulse wave mode to use. This is the most needle decrease depth 0.3 to 4 millimeter, but for periorbital skin use very superficial. For potenza, we use both monopolar and bipolar RF with a very superficial depth and use insulated gold-coated 25 CP25 pin to promote collagen production and trans-epidermal drug delivery. And this is the angle upward for the upper eyelid on bone technique, and the lower eyelid on bone technique and angle the handpiece downward, low pressure, do not direct stamping over the globe. This is anatomical rationale, the structural transparency issue. The skin cover to the upper eyelid and lower eyelids is superficial. Underneath the skin, there's muscle and vasculature. When the skin more thinner and thinner, you will see a muscle and vasculature color underneath. So why I want to improve skin collagen production and elastin to treat this. This is a veiling effect, increased thickness of the skin, and the appearance of the patient is good. 2% PNHPT. 2% PNHPT is made from tau from and DNA from Italy, used 20 years ago with high technology purified with low protein contamination, with high temperature procedure. So I can combine with monopolar and bipolar RF together in the same time. PNHPT support dermal fibroblast and producing collagen and elastin production. And sometimes it's increased fibroblast, collagen, and elastin synthesis, and why decrease inflammation. And this is my protocol on bone technique. And this is the result. The patient have a very satisfied result with creepy skin appearance that HA filler cannot do, botulinum toxin cannot do. She come to me to do a facial rejuvenation and skin rejuvenation. But I asked myself that, can I do the periorbital region too? And this is the result with great after 6 month follow-up. And this is the result, increased dermal thickening and decreased pigmentation. Again. For the upper eyelid, we can use Silphum X2. And 2 cases, I have improved clinical aponeurotic ptosis. I think the eyelid anatomy, when you open the eye, the levator muscle is action, and the levator muscle has its aponeurosis attract directly to the skin. When we contract the skin, it's improved. And this is the satisfied result. She was grateful. It's not accidentally fine. I can repeat it. And the result is last for 1 year, almost 2 years. And my dermatocalacia is also improved. And this is the technique. Angle upward on bone technique, gentle pressure, and use multiple paths. For moderate to severe case bipolar and monopolar with 2% PN was add, this is the satisfied result with patients with potenza and bipolar. This is 3 month follow-up, only single session. For under eye darkening, it's improved too. For moderate and dermatocalacia with mitosis also improved with 60 years old women who don't want to get any surgery. And this is the technique. On bone technique, use CP25 vision tips together with 2% P and without any injection. It's very, very safe to our patient. Can do together with under skin rejuvenation. This is their profile, minimal invasive, rapid recovery just 1 to 2 days, and natural aesthetic, avoid overfill looking with HA filler, and 0 complication. As a physician, there are 3 key points. Is the safe for our patient? Is its effectiveness good? And is naturally resolved? And this protocol achieve of 3. In 2026,
Sorry, you have to stop.
Okay,
Time's
thank
over.
you.
Thank you.
Just keep going because we're already past the time. Oh. Very nice cases that you presented. I was just curious. You said 0 complications in 1,700 cases, and I guess you were referring to like ocular injury. I think you said no cases of PIH.
Yes, no.
Bruising, anything? I mean, to have 0 issues with 1,700 cases
Yes,
seems
0.
exceedingly low.
Yes, because I think it's very, very superficial needle depth, and with MNRF, it's no bruising. It's not the same with micro needling without RF. Yes, no PIH, no bruising, no edema.
And what do you have them use afterwards for the wound care and the healing? Anything?
I use only Cicapac B5. Yes.
Okay.
Largely Cicapac B5 to promote wound healing.
All right. Thank you very much.
Thank you.
Good evening, ladies and gentlemen, distinguished guests, and members of the panel. My name is Dr. Wanwalang Visuthisap, and I am a fourth-year resident in dermatology from Ramathipati Hospital, Bangkok, Thailand, and I'm applying for the Rising Star Award. Thank you for the opportunity to share our study entitled Efficacy and Safety of Incobotulinum Toxin A for Jawline Acne, a split-phase randomized study. Acne vulgaris involves multiple pathogenic mechanisms, including increased sebum production and inflammation. Although topical and systemic therapies are effective, many patients continue to experience persistent acne or treatment-related adverse effects. Recent evidence suggests that botulinum toxin type A may reduce sebaceous gland activity through cholinergic inhibition, making it a promising adjunctive therapy. Interestingly, the prevalence of jawline acne has increased in recent years, potentially related to hormonal factors, cosmetic use, and prolonged mask wearing. This clinical subtype has therefore gained increasing attention. In addition, the jawline is a relatively safe anatomical site for intradermal botulinum toxin administration, with minimal risk of unintended diffusion to major facial muscles, supporting its suitability for a focused therapeutic investigation. The aim of this study was to determine whether intradermal incobotulinum toxin A could enhance the efficacy of standard topical therapy. Importantly, we focused specifically on the jawline acne using a split-phase randomized design. We conducted a randomized split-phase study involving 30 participants. Each person served as their own control, minimizing inter-individual variability. One facial site received topical benzoyl peroxide adapalene alone, while the other site additionally received intradermal incobotulinum toxin A. Various outcomes were assessed at baseline and at 1, 2, 3, and 4 months after treatment. Injections were performed intradermally within anatomically defined safe zones. Special attention was paid to avoid diffusion into lower facial muscles, particularly on the depressor anguli oris and rasoris muscles. We evaluated both subjective and objective outcomes. Subjective outcomes included lesion counts, and acne severity was evaluated using the investigator global assessment. Patient-reported outcome included pain score, perceived acne improvement, and satisfaction measured using a visual analog scale and documentation of adverse events. The objective measurements were facial pore volume assessed by anterior 3D imaging on the jawline areas, and sebum excretion measured using a Cebu scale at 5 cm lateral to labial commissure. For the result, acne lesion counts were categorized as comedones and inflammatory lesions. The most notable clinical finding was the significant reduction in comedonal lesions on the incobotulinum toxin A treated side at 1 and 4 months compared with the topical monotherapy side. In contrast, inflammatory lesions improved similarly on both groups. This suggests that botulinum toxin primarily affects early acne pathogenesis through sebaceous gland modulation. A progressive increase in the proportion of participants achieving IGA score less than or equal to was observed in both treatment arms, with no statistically significant between group difference. Treatment was well tolerated. Importantly, no serious adverse effects or facial asymmetry were observed when injections were performed within the defined safe zones and at appropriate intradermal depth. Patients also reported significantly greater satisfaction and perceived acne improvement on the incobotulinum toxin A treated side. This picture demonstrates clinical improvement of the patient. Objective imaging demonstrated significantly greater pore volume reduction in the incobotulinum toxin A treated side across all follow-up visits. Anterior 3D images show changes in pore volume. For mean sebum production, a significant reduction in mean sebum excretion over time was observed in both treatment arms from the first month of the follow-up and at all subsequent visits compared with the baseline. At the 3-month follow-up, the incobotulinum toxin A treated side demonstrated a significantly greater reduction in sebum excretion compared with the topical monotherapy side. For the discussion, botulinum toxin type A can inhibit several pathogenetic components of acne development, including follicular hyperkeratosis, inflammation, and sebum production via blockage of cholinergic signaling and other neurotransmitter pathways, and also reduce pore size by increasing the sympathetic response of the erector pili muscle. In our study, treatment with intradermal incobalamin toxin A was associated with overall improvement in acne severity compared with the topical benzoyl peroxide adapalene monotherapy. Although most outcomes demonstrated significant improvement, the reduction in inflammatory lesion counts did not reach statistical significance, despite the known moderate effects of the incobalamin toxin on the inflammatory pathway. This may be explained by the relatively small number of inflammatory lesions confined to the jawline areas. And also the increased interleukin-1 in inflammatory lesion is not inhibited by the botulinum toxin. Similarly, changes in IgA did not show significant between group differences, likely due to a narrow graded range, as all participants has a baseline IgA score of 3, and most achieved a score of 1 at the study completion on both sides. The major strength of this study is the randomized split phase design, which minimizes inter-individual variability. Additionally, the findings incorporate both objective and patient-reported outcome measures, which have been limited in previous reports. Further large-scale, multi-center studies involving additional facial regions are warranted to confirm the efficacy and safety of incobalamin toxin A on acne vulgaris. In conclusion, adjunctive intradermal incobalamin toxin A demonstrated favorable efficacy and safety for jawline acne, offering additional benefits in improvement of comedonal acne, pore volume reduction, and sebum control. Compared with the previous studies, our work provides stronger direct clinical evidence supporting the role of botulinum toxin A in acne treatment. Thank you very much for your attention.
Thank you so much. Very nice presentation. Short question. Why jawline acne and not full face? It's the first one. And secondly, economic-wise and ethic-wise, to which of your patients with acne would you propose this kind of treatment? Thank you.
Thank you for the question. Well, for the first question, why jawline acne? Because jawline is a very relatively safe area in comparing with other area on the face. So we can reduce the adverse effect that can cause maybe for the muscle weakness or something. Yeah. So I think for in the research, this is quite very safe zone for the injection. And for the second question, which type of patient? For this treatment, normally we start with a topical treatment, right? But maybe in some patient who has irritant contact dermatitis, for the standard treatment, yeah, for the oral resistant case, yeah, we can choose additional therapy. Thank you very much.
I have a quick question about the add-on effect, because the main treatment actually is benzoyl peroxide, which is a super powerful medication. So you can see at the first follow-up time period, actually, that all the patient improves at the same time. So, and also the difference between this group actually very, very minimal. So that the significance in biostatic actually doesn't mean that the treatment will provide enough benefit, clinical benefit. So that's why you choose the topical to combine with the toxin injection, is that probably you can choose a weaker one. So probably you can see the difference between these two groups.
Because we can compare in order to compare the effect of the treatment here. So we both give the topical treatment on both sides. So we can if our research didn't work, yeah, the patient also received the treatment Yeah. So we choose like the topical therapy first as the baseline treatment, and we add the Botox into the research. Yeah, because the patient can get the benefits. Yeah. No, no facial asymmetry observed. Thank you very much.